السلام عليكم ورحمة الله. طبعا أنا يسعدني ويشرفني إن احنا نبتدي نintroduce سيشن النساء في أكبر مؤتمر لكلية الطب، الجلسة الخامس والأربعون للسنة 45 متتالية. المؤتمر ده أكبر مؤتمر بتنظمه كلية الطب جامعة عين شمس، ويشرفنا إن احنا نبتدي النهارده سيشن النساء. سيشن النساء بتاعتنا إن شاء الله هتبقى including subjects the first time to be discussed in Egypt. The first time to be discussed in Egypt. صراحة اللي شجعنا وأيدنا ودعمنا إن احنا نحاول نظهر بهذا المظهر هو السيد الأستاذ الدكتور عمرو بيه الحسيني. صراحة كان أولا سبورتيف جدا، أبديتد جدا، بيخلينا نعمل كل حاجة على آخر ريسنت ايفيدنس. فاحنا بنشكر حضرتك يا دكتور عمرو أولا على تواجد حضرتك وعلى دعمك وعلى رئاسة القسم والمجهود اللي حضرتك بتعمله. واحنا طبعا يشرفنا إن أول محاضرة هنبتدي بيها هي محاضرة أستاذ الدكتور عمرو الحسيني على الإيجيبشن اكسبيرينس ان روبوتك سيرجري، وإن شاء الله تبقى محاضرة ممتعة ومتميزة كالعادة. اتفضل يا بيه.
اي سي بس ممكن نشغل المونيتور.
المونيتور عندهم مش لا لا هنا لا
مونيتور.
Good afternoon. It's a great pleasure to be among friends here in the 45th annual conference of our university. I have a great pleasure to be among my friends, Professor Sobhi Abullous, who is my mentor, Professor Ahmed Rami, the previous chief of our department, and my great friend, Professor Ashraf Fawzi, Professor Mohammed Al-Sayed, Professor Sharif Habib, Professor Karim Wahba, and my dear friend, Professor Mohammed Hussein, the coordinator of the conference. My presentation today about the Egyptian experience in robotic surgery, which I consider our experience is still in its infancy. We started this experience only 3 years ago. And at the beginning, just to let you know, we wanted to purchase the most famous and the gold standard robot in the world, which is Da Vinci robot from USA, produced by Intuitive company. But unfortunately, the company refused to let us buy this robot due to the previous experience in the Egyptian market and their financial study that or feasibility study that there will not be a great demand for the robot. So we shifted to another company which is called CMR from Cambridge Robotic in the UK, and they have a very advanced robot as well, known as the Versus robot. This is my country, our Nile, and congratulations for our world-class player, Mohamed Salah. He had renewed his contract today. All the best for Mohamed Salah. And this is our hospital, the largest maternity hospital in our country, with a number of deliveries unmatched except in 2 countries, in China and in India, about 15,000 deliveries per year, with all the subspecialties present in this hospital. This is a totally independent hospital with its own blood bank, its own ICU, its own renal dialysis unit, its own imaging, and all the subspecialties are expressed in this hospital, including assisted reproduction, minimal access surgery, IVF, oncology, gynecology, fetal medicine, and it's the tertiary referral center for obstetric and gynecology from all over the country. As I said, our university recruited doctors from the general surgery department, from urology and from gynecology to go for the CMR hub in Emirates for training, as well as a group of nurses to get their proper training in United Arab Emirates. The number of doctors trained, there were 2 doctors from gynae and obstetric department. I was not among these doctors. There were 2 doctors from general surgery and 3 doctors from gynecology. Later on, I joined this group. I didn't go for a specialized training in the UAE due to financial issues, but I had my training here. As I said, the specialties involved are urology, general surgery, and gynecology. In gynecology, there are now 3 consultants, and the following procedures has been done robotically. My other 2 fellows, Dr. Mohammed Abdel Fattah and Professor Rihab Abdurrahman, have done robotic hysterectomy. I've done the other procedures: robotic radical hysterectomy, robotic excision of deep infiltrating endometriosis with bowel involvement, robotic myomectomies uterine and cervical, robotic trachelectomy following previous hysterectomy, robotic repair of scar niche, and also robotic uterine and vaginal suspensions. We all know how the Da Vinci robot looks like, but how it looks like this new robot. I want to tell you that there are many companies worldwide are starting to produce the robot after the end of royalty for Da Vinci. Let's first start from China. Professor Jiang from China is here. There is a robot made in China, and it's a very efficient robot. There is another robot made in South Korea. There is another robot in the United States. There are different companies, but the most famous robot now after Da Vinci in the United States is the Hugo. The Hugo, like Hugo Boss, the Hugo from Medtronic. If you don't know, Medtronic is the largest medical equipment and medical consumables company in the whole world. Medtronic, it's the largest. There are some attempts for also other countries like Brazil. There is a prototype in Brazil, and also there is a prototype in Australia. For the most famous laparoscopic company in the world, Karl Storz, also they have a prototype. I visited them last year, and I have seen their prototype, and they're in their headquarters in Stuttgart. This is the main thing that differs the Versus robot from the Da Vinci, is that it's an open console. Open consoles mean that you can communicate with the staff in the room. You can see the patient. You have fresh air instead of going with your head inside the control unit of the console. So you are totally isolated and stressed during the procedures. You don't see anything. But here it's an open console which can work both 3D and 2D. It's your choice as a surgeon to work either with 3D glasses or without the 3D glasses. And again, here all the controls are present in the fingertips and the palms of the surgeon. There are no pedals at all in comparison to the Da Vinci, and it's really a user-friendly console. The other difference is that all the arms of the robot, each arm is mounted on a separate card. So it's up to you to use 2 arms, 3 arms, 4 arms, and these arms are really very mobile, so you can transfer them easily from one side to the other side of the patient if you like, and you can easily transfer them between one room to the other, so it's a very mobile robot. So this is how the theater we are working in, how it looks like. Each arm is mounted on one robot. There are many slave screens distributed in the theater, and the control unit where the surgeon is sitting is in the same place, and you can see everything in the theater. What's very nice in this robot is that also you can use normal disposable ports like the laparoscope. You don't need to use a specific port like the Da Vinci, so this is more economic. But it's preferred to use the specific ports, 8mm ports supplied by CMR, so you reduce the shaking of the arms while you're using it, because it happens sometimes while you are using the 12mm ports. Of course, the distribution of the ports is different from laparoscopy, because you try to put the ports in a way that minimizes the clash between the arms while you are operating. So every arm is on a separate port. I was the first person here in this country to use 4 arms. Everybody else is using 3 arms till now. They use one arm for the camera port and 2 arms for the surgeon, usually one with a bipolar and the other one with a monopolar scissor like the Da Vinci, but I prefer to use an extra arm down there for traction, and this will make you independent all the time on the assistant. Your assistant will only help you with the suction, but most of the time I'm working independently with the 3 arms. The disadvantage is that you have more clashes between the arms while you are working, but with proper arm position and orientation to your instruments, you can reduce the clashes between the arms. Now we go to a very important point in our discussion, is how much does it cost to do robotic surgery. This is very important point in a country which is price sensitive. The thing is that we cannot compare this to an open surgery. We have to compare the robotic surgery to laparoscopic surgery. The thing in the laparoscope, now we are all using harmonic, we are all using ligature, and we are all using disposable ports and sometimes disposable graspers. In the robot, if you use what's my fellow surgeons call hybrid techniques, where they use the harmonic for the dissection at the beginning of the procedure, especially the urologist and the general surgeons, they use the harmonic and the ligature, you will add a lot of cost to the procedure. But if you are, like myself, not using anything except the robotic arms, which are reusable or partially of limited use, you can use each instrument for up to 8 times, the difference in the cost is not that massive. But in average, the cost of the robot per case is around $3,000, not including the surgeon fees. That's the average per case. I can show you here, for those who are interested in robotic surgery, we have a case here of deep infiltrating endometriosis. One thing you will face at the beginning of your experience with robotic surgery is that you don't have a harmonic or a ligature. you only have a bipolar and scissor. There are advanced instruments available now in the Da Vinci, including harmonic but non-articulating. It's a non-articulating instrument, and a similar instrument to the ligature, which is articulating. It's also available in the UK, but it's not available in the market here, but it will be in few years. The main advantage of the robotic surgery is that the control of the view. The surgeon is the one who is controlling the view. It's not your assistant. Your assistant in laparoscopic surgery tries to show you the field he thinks that you want to see, but it's not what you really want. What you really want to see, you can control it with the robotic surgery, in the robotic surgery, because you are the one who is controlling the camera. The other thing is the articulation of the instruments, the 360 articulation of the instruments, which made a massive difference when you are working deep in the pelvis, especially in the pararectal spaces and in the rectovaginal space. This is very important, especially in cases of endometriosis, in cases of oncology, in cases of cervical fibroids. It's extremely essential. You can see here, we are opening the rectovaginal septum with ease, just one surgeon operating and only the assistant at the vagina, helping with stretching the vagina just to show us the landmarks, and we can easily remove the endometriosis nodules from the uterosacral, from the torus uterinus, and you can achieve this with maximum comfort. In addition, it's very important to mention the comfort of the surgeon. The surgeon is sitting, you can have a sip of water while you are operating, you can have a break for 1 or 2 minutes. If you are doing advanced endometriosis surgery, which may take 4 or 5 hours, it's really very important to grasp your breath. The other thing that you can really work till you are really very old. I know some robotic surgeons who are 80 something and still operating in the States till today, and they are very efficient surgeons. In addition, if you are doing something like excision of endometrioma, if fertility is not a concern, you can do that single-handed with the 3 arms of the robot, and the dissection is amazing, as you can see here. Also, in cases where you have a cervical fibroids, the suturing of the myoma bed is sometimes tedious due to the angle you need to use to suture the myoma bed. Here I'm using a different tool. I'm using a bipolar scissor and a monopolar hook. We are isolating the ureters, just a safety step at the beginning, and then here is my assistant. She is grasping the myoma and pulling on the myoma, because you don't have a similar tool so far in the CMR or the Versius robot, but it's present in the Da Vinci. The Da Vinci will always remain the gold standard, although most of the companies now are opting for the open console. And I think that Da Vinci at some stage will have an open console, because it gives air communication to the main surgeon. Now we have almost moved or removed most of the myoma, and the field is showing minimal bleeding. But what I want you to see really is how we are going to suture this very deep in the pelvis. Here I'm using a barbed suture, of course, but you can take any angle in the sutures which is much easier than laparoscopic surgery. Laparoscopic surgeons know that suturing in this area is really tedious and takes a lot of time. Here you can do it much faster and more accurate. And in the second layer, we are doing baseball sutures, in-out sutures, I mean, and it works very well in this case. So there is a role for robotic surgery. It is coming. It will take some time. Now there are 4 robots in this country, one in the urology unit in Al-Qasr Al-Aini, Cairo University, one at Ain Shams University, and one at Cleopatra Hospital, and one at International Center for Urology, which is a private center. Whether we are going to have Da Vinci robots in this country, I think it remains to be seen, but from my experience, I think the experience and the benefits of robotic surgery are quite good. Thank you very much.
Thank you, Professor Amr Al-Husseini, for the outstanding presentation, not only presentation, outstanding work. And I think you are among the very rare surgeons worldwide, not only in Egypt or Middle East, but also in the whole world, to work like that by robotic surgery. You are from the first surgeons to start it. Thank you, sir, for the beautiful, outstanding work and presentation. And now we are coming to the second presentation, and it would be mine. دكتور صبحي بيتفضل.
بسم الله الرحمن الرحيم. يعني يسعدني جدا ويشرفني جدا ان يعني اكون في صحبه المجموعه الجميله جدا دي. اخي وزميلي وصديقي وابننا العزيز الاستاذ الدكتور محمد حسين مصطفى، صح؟ ماشي. الحقيقه هو من احد الشخصيات المتميزه الجريئه. He's a brave doctor. The presentation today is the AI, artificial intelligence in the IVF era. قبل كده كان الأستاذ الدكتور عمرو حسين بيتكلم على robotic surgery in the era of new surgery. In the past we do open surgery, open and see, laparotomy, then we do mini surgery, mini laparotomy, then we do K-hair surgery, laparoscopy, then we shift to the new era of the robotic surgery. The life is progressing, and you are a very brave doctor to do that surgery at this time in our country. Dr. محمد حسين تفضل سعادتك كلمنا عن AI in the IVF.
شكرا أستاذي العزيز. Thank you, dear sir. And we are now starting the second presentation, the AI in IVF. And as we know, the IVF market is increasing largely in the last years. احنا أول حالة IVF في العالم كانت 1978 أول حالة IVF، ومنذ ذلك الحين حتى الآن احنا لنا أن نتخيل إن في 12 مليون طفل اتولدوا. 12 million babies were born all over the world by the IVF. The rate globally is about 4 million yearly. 1 million baby yearly is born by IVF. So the IVF market is huge and increasing. In dollars and in market, this year, 2025, the market of IVF exceeds $30 billion. $30 billion. السنة دي كان 2025 في رقم ضخم جدا، اكثر من 30 مليار دولار انفق على الاي في اف. متوقع ان خلال this decade بعد 9 سنين هيكون وصل الرقم لحوالي 70 مليار دولار. 70 مليار دولار. الحجم ده طبعا في الدبل، اكتر من الدبل. احنا حالات الاكزي بتزيد نتيجه ان احنا عندنا رايزنج ايج اوف ماذرز، ديليد مارج، والمين ايج اوف مارج دلوقتي بقى معدي 28 سنه according للبيبرز 28.6 and there is rapid decline in fertility among females and males. واحنا لاحظنا حتى بعد الكوفيد في الفتره الاخيره وبعد الفاكسينيشن اوف كوفيد لقينا ان في ناس كتير الاي ام اتش بتاعها بدا يقل وعندها بريماتيور اوفيريان فيلير and they are now growing acceptance for IVF، وناس كتير جدا بدات تتقبل الفكره، وده زود حالات الاي في اف جامد. التشالنج بتاع الجروث دوت قابله مشاكل، ان في عندنا كوست باريرز وفي ليميتد انشورنس، وما زال في بعض المناطق في عندنا مشاكل دينيه واجتماعيه وكالتشر من انها تواجه المجتمع وتقول انا عامله اي في اف. احنا بنشتغل اي في اف تراديشنالي، وايه المشكله اللي بتواجهنا عشان خاطر نبتدي نلجا للاي اي؟ عندنا مشاكل كتيره جدا. اول حاجه ان IVF we are relying in human experience only, it is subjective, only human experience. يعني احنا دلوقتي عشان نقول العيانه ديت هتاخد induction protocol, long protocol, antagonist protocol, short protocol, whatever the protocol, we are relying on what? On the surgeon, on the observer, on the doctor. And there is no fixed protocols. يعني العيانه لو راحت النهارده ليا وراحت بكره للدكتور كريم وراحت بعد بكره للدكتور احمد الحسيني، كل دكتور فيهم هيقول ممكن بروتوكول مختلف بادويه مختلفه بدراجز مختلفه. there is no fixed بروتوكول، ودي مشكله. وبالتالي احنا لا البروتوكول ثابت ولا الادويه ثابته ولا الستارتنج دوز اوف HMG ثابته ونقدر نثبتها في الناس كلها، ولا الفولو اب. لو العيانه جت عملت لها فولو اب فوليكولومتري ولقيت ان عندها فوليكلز سي رقم معين بحجم معين، لو راحت للدكتور اللي جنبي هيقول لها رقم تاني بحجم تاني، وراحت للدكتور اللي بعده هيقول لها رقم تالت بحجم تالت. وبالتالي لما نيجي نسحب حتى البويضات ونحقنها الموضوع بيخرج من ايدينا تقريبا وبيبقى في ايد دكتور المعمل، ودكتور المعمل كل دكتور معمل ممكن يتصرف بطريقه غير التاني، وممكن يبقى فيه مشاكل وممكن يبقى فيه عليه ضغط جامد جدا، وبالتالي يبقى في عندنا برضو مشاكل سبجكتيف في الدكاتره اللي موجودين لغايه ما خطوه نقل الاجنه ثم مرحله ما بعد نقل الاجنه، كلها حاجات سبجكتيف and there are no fixed rules at all in IVF. وبالتالي there is lack of personalization and ethical concerns include invasive procedures زي ال PGTA دي invasive procedure، وهنشوف الاي اي ازاي ممكن يحل هذه المشاكل. الكوست بتاع الاي في اف بيعلى، وكل ما بيبقى فيه اكسبيرينسد ستاف كل ما بيزيد اكتر الكوست، وكل ما بتزيد التقدم بتاع المراكز كل ما الكوست بيعلى. على الرغم من كل ده احنا عندنا very limited success rate، وبنتكلم في ان السكسس ريت بتاعنا ما بيزيدش عن 40% success rate. So the use of AI in IVF is one of the promising advances. احنا عندنا في الاي اي هنستغله في كذا اتجاه. اول اتجاه ان احنا امبريو سيلكشن. الامبريو سيلكشن بتاعنا should be precise embryo selection، هيبقى احسن من الامبريولوجي بانه faster and more accurate and improves the IVF success rate زي ما هنشوف. and the treatment plans will be personalized for each person for each patient. هندخل الداتا للكمبيوتر، والكمبيوتر هيقول لنا احسن دواء للعيانه دي كذا بالستارتنج دوز كذا بالبروتوكول الفلاني. and even in genetic testing which includes PGTA we can do it by AI non-invasively، وهنشوف دلوقتي. احنا الاي اي موجود في حياتنا اليوميه، واحنا كلنا بنستخدم الاي اي. يعني عشان امسك الموبايل واحطه قدام عينيا ويفتح، ده الفيس ريكوجنيشن، ده اي اي. لو انا طلبت تاكسي اوبر عن طريق الابلكيشن انا كده بستخدم الاي اي. في بعض الحتت زي تسلا في عندها اوتوميتد بايلوتس بيوصل بالابلكيشن يوصلك من غير سواق للحته اللي انت عايزها، كل ده انكلودنج اي اي. وبالتالي الاي اي ماركت اوريدي موجود، بيصرف وبيتصرف عليه ارقام مهوله جدا. احنا السنه دي اتصرف على الاي اي 760 بليون دولار، 760 بليون دولار جلوبالي. متوقع بعد 10 سنين او 9 سنين الرقم هيبقى 3.7 تريليون. $3.7 billion invested in AI market. So we have to do it. الاي اي في الاي في اف احنا هنستخدمه في حاجات كتير. هنستخدم تايم لابس امبريو ايمجنج فور كونتينيوس مونيتور وذاوت امبريو ديستربنس. وعندنا كانت مشكله كبيره ان احنا عشان نطمن على الاجنه لازم نفتح على الاجنه ونبص عليها، وده بيعمل ديستربنس للامبريوس. حتى بالحضانات الذكيه اللي موجوده برضو ما بيحلش المشكله. and enhance embryo selection with overall success rate. بالنسبه للاي اي هتبيرسوناليز البيشنت تريتمنت وهتحدد لكل عيانه هي محتاجه ايه، وهيفيدنا برضو في الكارير بريزرفيشن اوف اوسايتس. and this will increase the accuracy of embryo selection by 25% and decrease the risk of miscarriage and abortion by about 20%. زي ما اتفقنا احنا الاي اي موجود في حياتنا. الاستخدام الفيزا دوت اي اي، الاوبر دوت اي اي. الاي اي عشان نفهمه هو ويف، تكنولوجيكال ويف providing the ability for a machine to mimic the human, to act like the human. And the AI machine needs machine learning, which is a subset of AI technology and includes statistical methods to enable the machines to learn from experience. So we have to use deep learning, machine learning, and AI. Machine learning like that figure. احنا عشان نعلم الاطفال نقول لهم ايه يعني ايه سيركل ويعني ايه مربع. هنقول له والله احنا لو عندنا 4 ضلوع متساويه يبقى ده سكوير، في حين ان انت لو مش عارف تعد اي ضلوع للشكل اللي قدامك اتس ا سيركل. الماشين ليرنينج مش كده. الماشين ليرنينج هنحط له المنظر ده ونقول له دي سيركل وده سكوير، وبالتالي اي حاجه هتيجي في وشه كده هتقول ده سيركل وده سكوير. ده مثال بسيط. بعد كده بعد ما بنحط له الكلام ده بيبقى في حاجه اسمها نيورال نتورك. النيورال نتورك ديت بيبقى فيها كذا نيورونز. احنا بنشبه بالظبط بالمخ عشان كده هو بيسموه نيورونز. والنيورونز دول بيبقوا interconnected by lines and these neurons will be put in layers. The first layer will be the input layer, then the hidden layer, then the output layer. في خلاصه الكلام ده في الاخر عشان بنغذي الجهاز بالداتا عشان يطلع لنا في الاخر المعلومات المتناسقه وينظم المعلومات. So the machine learning is a statistical method and the AI is intelligent machine like the human. دي الخطوات بتاعته اللي هو deep learning, machine learning and AI. We will go through the IVF and AI assisted embryo grading has been shown 96% accuracy compared to embryologists, which is only 75% accuracy in embryo grading. These are the programs and the models available for using the AI, and now we are starting the model. هنقول للماشين احنا عايزين نعمل IVF، فالماشين هتقول لك حط لي حاجتين، حط لي الديفايند اوتكم بتاعك واديني كل الداتا and factors that will affect that outcome. فاحنا عندنا في الاي في اف ايه الاوتكم؟ ايه الديفينيتيف اوتكم بتاعنا؟ ايه هو؟ ان الست تحمل تجيب بيبي، صح؟ وهنحط له كل الداتا اللي مطلوبه. فاحنا الاوتكم بتاعنا ان احنا نحط بيبي، ان احنا نجيب بيبي، وبالتالي هو ده الاوتكم. طب عشان نوصل للاوتكم عايزين جود كواليتي بلاستوسيست. عشان ندخل الداتا عايزين فيري بيج داتا عشان ندخله ونوصل المعلومات ببعضها ونقول ازاي وصلنا لهذه النتيجه. زمان كان الراجل والست بيمشوا هذه الطريقه، هم كده ماشيين على رجلهم وهيمشوا through the journey of ART. والجيرني ديت لما دخل الاي اي بدا يتدخل في كل النقط الاتيه، في التشانس اوف سكسس، في الاوبتيمال ييلد اوف ماتيور اوسايتس، في prevention of early and late ovarian hyperstimulation syndrome, oocyte selection, sperm selection, embryo selection, embryo ranking, embryo viability. يعني احنا كنا نقول للمعمل هو البيبي اللي انا هزرعه ده عايش ولا ميت، ده فايبل ولا مش فايبل، ده هيكمل ولا مش هيكمل. يقول لك احنا هو دلوقتي كويس، هيكمل ولا لا الله اعلم. embryo viability, uterine receptivity and endometrium receptivity يبقى اسيست بالاي اي. لابوراتوري بيرفورمانس والمعمل نفسه هيبقى اسيست، وايفن البيشنت اللي هتبقى دروبد اوت will be assessed by AI ونشوف هي دروبد اوت ليه. طبعا احنا ده الاوتكم اللي احنا عايزينه، بنقول له احنا عايزين نشوف التشانس اوف سكسس فهيقول لك دخل لي الايج والاي ام اتش والديوريشن اوف انفيرتيليتي اند بودي ماس اندكس وحاجات كتيره جدا. هنقول له عايزين نشوف الاوسايت كومبتنس، هيقول لي الكرايو كومبتنس والديفلوبمنتال كومبتنس. طيب انت هتدخل لي الاستيميوليشن كاركترستكس والتايمنج بتاع الاتش سي جي وانت اديت دوز شكلها قد ايه. امبريو فايابيليتي هيتكلم على البيشنت فاكتورز اللي فاتت مع المورفوكاينetics مع الميتابولو ميكس اللي هي استهلاك الجنين داخل الحضانه للاكسجين والجلوكوز واللاكتيت والبيروفيت والاكسجين كونسومشن. الجنين ده كان محتاج قد ايه واستهلك قد ايه في الحضانه. كل دوت will be monitored by AI. البي جي تي اي هنستغنى عنه وهيبقى نون انفيزيف. laboratory performance also will be assessed by AI زي ما اتفقنا. وبالتالي بدل ما هم كانوا ماشيين على رجليهم بقى راكبين دلوقتي العربيه دي. وبالتالي with the rapid pace of computer and genomic science the future of reproductive medicine is seen to be personalized وهتبقى زي الديجيتوم. ديجيتوم يعني personalized digital fingerprint موجوده في البيشنت ريكوردز. هتورينا الفارماكوجينكس والكلام ده طبعا احنا ما هواش خيال، الكلام ده موجود في اسرائيل ويو اس اي بقاله اكتر من 6 سنين شغالين بيه واشتغلوا بيه حالات كتيره جدا. الاي في اف تريتمنت اندكشن زي ما اتفقنا هيحدد لي الانيشال اف اس اتش دوز وهيحدد لي احنا ماشيين ازاي ومحتاجين نزود الدوز ولا لا. طب الكلام دوت فرق؟ ايوه فرق في انه قلل الدوز بتاعه الاتش ام جي 195 وحده، يعني قللنا حقنه ونص من ال 150 وفي نفس الوقت احنا قللنا الدوز وزودنا الام 2 اوسايتس كان بنسبه 1.5. الادفانس في الناتشورال لانجوج بروسيسنج يعني العيانه وهي قاعده بتتكلم كان توك وذ ذا اي اي، تساله على اسئله اللي هي عايزاها بدل ما تكلمك بالليل في نص الفجر وتقول لك يا دكتور بعد نقل الاجنه انا هقوم امشي ولا لا؟ يا دكتور احنا بعد ما هنسحب البيضات ينفع اكل ايه؟ ينفع اشرب ايه؟ ينفع اعمل ايه؟ هو هيرد عليها الاي اي ويقول لها كل الاسئله باي هير لانجوج. باي هير لانجوج وده بالنسبه لللانجوج بتاعنا. وهيفولو هير بالمود والسوشيال روبورتس هيدوروا على المود بتاعها وهيدوها اسيستنس كبيهيفيرال ثيرابي طول ما هي بتعمل الاي اي. الاي اي هي اكوردنج للالترا ساوند هيحدد لي ميعاد التريجر بتاع الاتش سي جي، واحنا احيانا كتير جدا ما نبقاش عارفين في asynchronous cohort of oocytes مش عارفين ندي الاتش سي جي امتى، وبالتالي الاي اي هيحدد لي الميعاد اللي حد فيه هذا التريجر والديسيجن اند تايمينج اوف ذا تريجر، وبالتالي ده هيزود فرصه ان انا اطلع ماتيور oocytes اكتر. اكتر برانش مهم جدا هو الامبريو سيلكشن and the embryo selection is very important واتعمل له سكورز كتيره واتعمل له موديلز كتيره جدا عشان يحسن الامبريو كواليتي. ده شكل البلاستوسيست، وده لما يبتدي الكمبيوتر يتعامل معاها يعمل لها زونا سيجمنتيشن اند زين سنترال امبريو سيجمنتيشن عشان يحول وياخد كل جنين من دول يدخله في الديب ليرنينج، يقول للاي اي موديل بعد كده يكون الاي اي موديل then it will be tested then it will be accurate and take with. دي البويضات بتاعتنا، ده البلاستوسيست، ودي احلى اشكال بويضات. على الرغم من كده احنا ما نعرفش الفيت بتاع هذه البويضات شكله ايه، والديسيجن ميكنج مش هو لازم هو ده مش كفايه، لازم يكون efficient decision making. وعشان يبقى efficient ينجيب very large number of experience and cost، يا اما نعتمد على الاي اي باللو كوست and it will be standardized and objective and available all the time. It is accurate, flexible and learning abilities and scalable. انا اقدر اقيمها واعدل فيها كل شويه، وده الامبريو سيجمنتيشن. وبالتالي non-invasive objective assessment can predict the implantation potential more accurate than the current grading. It is not expensive and practical to implant and with low cost, and it is transparent to the patient and the patient can follow up all of her steps from her home. Can be updated without changing the equipments and it is personalized. احنا ده الرانكينج بتاع الاوسايتس اللي بتاع الامبريوز، بندخله الامبريوز وهو يحط لي الرانكينج هنشوف دلوقتي. والكلام ده اثر وحدد لي 25% زياده في الاكيورسي بتاع ايه؟ بتاع الامبريو فايابيليتي. هيقول لي الامبريو ده فايبل ولا لا. ده مثال للموديل، ادي الموديل وهو فاضي هندخله الامبريوز بدات تدخل الامبريوز، هيقول لي الامبريو ده السكور بتاعه وحش ما تنقلوش، الامبريو ده بالاخضر السكور بتاعه ممتاز جدا، it is viable and it is very high chance for giving baby. وده الديب ليرنينج هيستبعد الاجنه اللي مش سليمه وهيقول لي الاجنه الكويسه. وبالتالي الكلام ده نتج عنه according to the studies ان البريجنانسي ريت زاد 25%، ان الاوفيريان ستيميوليشن بروتوكولز قل الريدكشن في الاوفيريان هايبر ستيميوليشن 20% زي ما 12 في اللانست، زود الامبلانتيشن ب 15%. and according to the shape and morphological structure of the embryo and behavior and the kinetic behavior of the embryo under the microscopy will assess the genetic structure and will correlate non-invasively the genetic structure of the embryos and the morphological structure according to the kinetic and subtle morphological changes in the embryos. وبالتالي هيحدد لي الاجنه الانبلويد من غير ما نعمل PGTA او ناخد الاجانين او نعمل حاجات invasive and costly. طبعا ده لضيق الوقت احنا هنعديه اللي هي ازاي بيأسس جينيتيكالي، وهنتكلم في النقطه اللي بعدها في السبيرم سيلكشن اند اوسايت سيلكشن. طبعا السبيرم سيلكشن احنا السبيرمز اندر ذا ميكروسكوبي يقدر احنا اي الامبريولوجيست يقدر يطلع السبيرمز موفينج ويقول لك دي موفينج ونورمال، ولكن لو عندي حاله تيراتوسبيرميا او اثينوسبيرميا او سيفير اثينوسبيرميا ممكن يقعد بالساعات عشان يطلع سبيرم وفي الاخر يقول لك انا ما لقيتش غير ده. الكمبيوتر مش كده، in less than 5 minutes will select very high quality sperms and moving sperms من غير ما ياخد وقت طويل، وده هيحسن الفيرتلايزيشن ريت بنسبه 22% او هيقلل ريسك اوف انيبلويدي في نفس الوقت. وبالتالي احنا عندنا سبيرم سيلكشن. طب اوسايتس والاوسايت كواليتي اللي احنا دايما بتبقى قدامنا كنقطه فيج، لا ات كان اسيت ذا اوسايت كواليتي ان كان بريدكت حاجات كتيره جدا، مش بس الماتيوريتي وهي M1 ولا M2 ولا GV، لا هيحدد حاجات كتيره جدا according للسيتوبلازميك جرانيوليشنز والفاكيولز والريفراكتايل بوديز والاندوبلازميك ريتيكولم والانكلوجنز اللي جوه السيتوبلازم والزونه وحجم الزونه والثيكنس والداركنس والبيريفيتال لاين سبيس. هياخد كل اوسايت ويديها شكل and this oocyte will be monitored and give a chance for being good oocyte for fertilization or not good oocyte، وهيعمل لي oocyte prediction for pregnancy from that oocyte. ده منظر البروجرام، بيدخل فيه الاوسايت وبيطلع لك ادي الاوسايت بكل البيانات بتاعتها. ومش بس كده، هيقول لك الاوسايت ديت can be fertilized by the following percentage and the pregnancy rate blastocyst rate by the following percentage. وده البرسنتج قال لك الاوسايت دي هتبقى تشانس اوف بلاستوسيست 76%، هنا 90%، هنا 80%. ابعد عن دول نسبه البلاستوسيست بتاعتهم مش كويسه، وده الفايوليت موديل اللي بيحدد. المهم في الفايوليت موديل ده ان البلاستوسيست اكيوراسي كانت اعلى من الامبريولوجيست زي ما احنا شايفين 62%، الامبريولوجيست 52%، في حين ان الفيرتلايزيشن ريت برضو كان في البروجرام 71%، ولكن في الفيرتلايزيشن باي ذا امبريولوجيست اقل من كده بكتير. وفي نفس الوقت جبنا 300 اوسايت اديناهم ل7 سينيور امبريولوجيست، وقلنا لهم حددوا الاوسايت كواليتي، خدوا 2 hours، في حين ان الفايوليت موديل خد less than 5 minutes. ومش بس كده، كان الاكيورسي بتاعه 62%، في حين ان الامبريولوجيست كانوا اقل من كده ب 10%. وبالتالي الاوسايت كواليتي بيحددها الاي اي. امبريو اندوميتريال ريسبتيفيتي اند the shape of endometrium، كلنا بنعتمد على الثيكنس بتاع الاندوميتريوم والشيب اوف اندوميتريوم. no it is not like that after AI. after AI هيعمل حاجه اسمها اندوكلاسيفاي موديل. ان اندوكلاسيفاي موديل ده هيعتمد على 3D الترا ساوند عشان يشوف الاندوميتريال جلاندز in the myometrium and then assess not only the thickness and the shape of endometrium but the endometrial glands. and this endocalcify الكلام ده زود الامبلانتيشن ريت برضو وحسن السكسس ريت. وبالتالي لو انا استخدمت الاثنين اللي هو الاي اي على الامبريوز and the endometrium it will give very high success rate in IVF. الاي اي will affect the lab itself وهتقلل الهيومن variability اللي موجوده وهتقلل الامبريو هاندلنج اند كلتشر كونديشنز. ولما عملوا اي اي دريفن انكيوبيتورز زود البلاستوسيست فورميشن باي 40%. وبالتالي كانت نسبه عاليه جدا. البنفيتس اوف اي اي زي ما اتفقنا it will increase the success rate in IVF and ICSI and it is faster and more accurate with reduced cost and it will give the patient personalized treatment with integration of genetic screening with non-invasive procedures fully automated and it can predict the viability of the embryos and the stimulation protocol. وفي الآخر لو استخدمنا الكلام ده متوقع بالاي اي برضو ان هيزيد السكسس ريت 30% within the next decade. IVF success rate will increase by 30% within the next decade. الكلام ده اللي نشروه في اسرائيل وفي اليونايتد ستيتس بعد ما استخدموا الاي اي هناك لمده 6 سنين. اللي تشالنجز ان احنا ازاي ندخله في كل الفيرتيليتي سنترز والايثيكال كونسيرنز، واهم حاجه سريه البيانات، وان العيانه البيانات بتاعتها هتبقى متاحه على السيستم طول الوقت وهتبقى متاحه ليا ولغيري، وده اللي هتبقى فيه مشكله. ولازم العيانين يبقوا بلايند وفي ايثيكال كونسيرنز. وهل ده معناه ان should the AI full automate the embryo selection? It is not automation, it is decision augmentation. It is not automation, it is decision augmentation. So it is augmentation of the decision. بدل ما الدكتور ياخد وقت طويل جدا يبقى فيه فلوس كتيره، critical decisions مش عارف ياخد قرارات، مش عارف يستفيد من حد، مش عارف يسال حد، هيلاقي الاي اي تكنولوجي هت improve the outcome and will help the doctor. They are not plug and play devices. الموضوع مش للعب، ولكن their devices to زي ما اتنشر في اللانست قالت scenario in which medical information gathered at point of care it is analyzed using sophisticated machine algorithm to provide real-time analytics seems to be within your touching distance. بزرار او دوسة الزرار بتاعك هتوصل لكل البيانات in no time. The machine learning is already being used and the power of machine learning is the ability to capture the value of big data and the guide decision making. والموضوع طبعا لسه مستمر. Take home message in each journey for each patient in IVF is unique and AI the future and the future is bright and life is finite while the knowledge is infinite. ولما نتكلم السنه الجايه على الموضوع ده او في ان شاء الله في الاسوجيك هيبقى فيه very updates باذن الله زي ما الدكتور اشرف وعدنا باذن الله. Thank you sir, thank you chairperson and thank you for the audience.
Thank you, Professor.
Yes sir. Yes please. Practical speaking, there is yes, with micro, yes, manipulators and self injection. Yes, it is present, it is available and it is present and it's working. يعني اللي موجود دلوقتي يا دكتور شريف بيه الموديل بتاع البيشنت، ان البيشنت ندخل الداتا بتاعتها، الموديل بتاع الاوسايت كواليتي، الموديل بتاع السبرم سelection، الانجكشن ده احدث حاجه ان هو في عملوا incubator microbate by AI to inject the oocyte. The incubator is managed and followed by AI. بياخد صوره للجنين كل 10 دقائق وفيديوز مستمره للجنين kinetic videos every picture every 10 minutes and videos مستمره لمده الثلاث اربع خمس ايام اللي الجنين موجود في الحضانه. and these videos and the kinetics بتدخل في analysis and statistics وهيقول لك according للي حصل اللي احنا ما شفناهوش اصلا، الاي اي بس هو اللي شافه، هيقول لحضرتك الجنين ده viable ولا لا، و percentage of blastocyst formation and percentage of pregnancy. you have تشتري جديد. لا طبعا هتشتري جديد كلها اي اي. بالظبط كده، زي بالظبط كده عندك موبايل اندرويد وعندك موبايل مش اندرويد، لازم تجيب الاندرويد، لازم تغير الموبايل.
الحقيقة أنا عايز أقول حاجة بس دكتور أحمد. إحنا the era of the IVF now changed completely، وبالتالي مطلوب مننا تعليم جديد، تدريس جديد، فكر جديد خالص. مراكز IVF يا دكتور حسين أحمد حسين اتغير، كل التكنولوجي هيبقى فيه أفكار جديدة خالص، والعلم مش هيقف عند محطة زي ما حضرتك اتفضلت. في تحسن حوالي 22% في 30% في الاند ريزلت من النتائج الكويسه جدا، وبالتالي عليكم عبء جامد جدا، واعتقد انها هتدخل في مشاكل الان القانون والقضاء والمعاقبه والمحاسبه في كل المشاكل اللي ممكن تحصل منها هذه الامور كلها. وبالتالي هو النولج وديب النولج الديب النولج هو ذا ايرا از كامينج از كامينج. شكرا على هذه المعلومات القيمه العميقه العزيزه. اتفضل بيه.
احنا بنشكر بروفيسور دكتور محمد حسين على الفيري انفورماتيف ليكتشر وعلى المجهود الجبار في تنظيم المؤتمر. Our next speaker, Professor Dr. Karim Wahba. He will talk about embryo transfer, the rate limiting step in assisted reproduction.
السلام عليكم. في الأول أنا بشكر الدكتور عمرو الحسيني وبشكر عميد الكلية وبشكر الوكلاء إن هم ادوني الفرصة إن أنا أدي سيشن in this prestigious الحقيقة conference. الحقيقة أنا هبقى a bit different شوية. I will be a bit different. I will speak a bit of Arabic, a bit of English. So it will be a bit an interactive session. It will be a clinically based session rather than an academic session. الحقيقة كلمة rate limiting step. What is the meaning of a rate limiting step? What is a rate limiting step in a chemical reaction? It is the most important step in a chemical reaction, and this step, without it, the chemical reaction will not be completed, and it needs the highest amount of energy. For this reason, I allowed this nice title. I always, in the beginning of any presentation, why did I do this presentation? First of all, many recommendations are unfortunately not evidence-based in the embryo transfer. So it depends upon personal experiences. The second thing is that if you improve proper embryo transfer, you will improve pregnancy and birth outcomes. 30% of failures of IVF or EXI depend upon failure of proper embryo transfer. I used to have a chat with one of my psychiatrist colleagues, and he did a very nice research about doctors. And in obstetrics and gynecology, he said 3 problems that face an obstetrician and a gynecologist. If happen, they can lead to depression to this person, to the doctor. First is to perforate the uterus in a D&C biopsy. Second is to not do a proper embryo transfer for an IVF patient. And third is to injure the ureter or the rectum or the sigmoid in either open surgery or laparoscopic surgery. So these are the 3 bad dreams of any obstetrician and gynecologist. Do you agree with that? So to minimize the unnecessary or harmful interventions, to avoid high expenses of multiple treatment failures, and to reduce the physical and psychological burden. And the last thing is the very important thing is to enhance single embryo transfer. We are one of the countries with the highest number of embryos to be transferred. وهقول لكم حاجة ظريفة جدا. وأنا بشوف فيديوهات كده على النت، لقيت فيديو لحد بيعمل امبريو ترانسفير، فالامبريولوجيست بيقول له احنا هننقل 3 أجنة. We are going to transfer 3 embryos. The surgeon himself said, how many embryos do we have? He said 5. He said, let's transfer the 5 embryos. In every step of IVF or EXI, we have losses. For example, if we are monitoring the cycle, an IVF cycle, we say we have got 20 follicles, but we end with having 12, for example, oocytes. We end with having later on 8 M2 oocytes. And then fertilization, we might have 5 embryos. So it's a matter of loss. But the only stage that we don't need any losses in is the stage of the embryo transfer, especially that we are enhancing now single embryo transfer. As we all know, it's a matter of a seed and a soil. So we prepare the best seed to be embedded in the best soil with the best technique and at the proper time. So what about the endometrial thickness, Dr. Sharif? What's the best endometrial thickness in which we transfer the embryo at? It is not standard, but many papers say above 7 millimeters it's acceptable. In fresh embryo transfer, most of the papers say it's between 10 and 12 millimeters is the ideal. So in fresh embryo transfer, between 10 and 12 millimeter thickness, but in frozen embryo transfer, it might be a bit less. In frozen embryo transfer, it might be between 7 and 10. So to round it up, around 10 millimeters endometrium is a good thing. Another thing which we don't do routinely is a 3D ultrasound for the endometrial volume prior to the embryo transfer. Literature states that less than 2.5 mils endometrium volume is bad, is not good, which should be placed into consideration. Definitely, we all know the steps. Patient education is very important. Some patients are so apprehensive before the step of the embryo transfer. So we need to explain, we need to even show her on diagrams. If she did IUI, we tell her it's a very simple procedure, it's similar to IUI. It's painless. She should have a positive attitude. I personally, in my personal experience, allow the husband to attend the embryo transfer. This makes it very, very easy for the patient. So the husband attends the embryo transfer. And both of them, before the procedure, they have a look at their embryos as well, both of them. Definitely, we need to have a full bladder, but not an over-distended bladder. An over-distended bladder invites micro-contractions to the uterus. An over-distended bladder invites pain to the patient. So this is not right. Definitely, if the patient is anxious, we need to give her sedation or general anesthetic. Check all the documents. And double check the patient's identity with the embryologist. This is very important. And as I told you, encourage the single embryo transfer. This is very important. In 2021, the ACRM concluded that in most cases, we need to do a single embryo transfer. Apart from several situations, like old patients, like not very good quality embryos, we might increase the number of the embryos. But as long as the embryo is euploid, so transfer only one embryo, even at the older ages. Actually, the ESHRI in 2024 changed things a bit. They said single embryo transfer, even whatever the stage of development or morphology of the embryo, justify double embryo transfer instead of single embryo transfer. So they are more enhancing single embryo transfer, even if it's a 3-cell, not a 5-cell, or not a blastocyst. And they definitely are stressing on the risks of multiple pregnancies and the risks of fetal reduction. As we all know, risks of multiple pregnancies, if we have only a single pregnancy, this will make pregnancy safe, enhances the vaginal delivery, decrease the risk of preeclampsia, diabetes, emergency cesarean section, preterm labor, increase the incidence of full-term birth and healthier childhood, and definitely decreases the financial and psychological burden on the parents. So single embryo transfer is the best. Day 3 or day 5, definitely we all agree that if an embryo can wait until day 5, it's much better than day 3 embryos. Although there is a bit of drawbacks. For example, some cleavage embryos do not develop into blastocysts. And some blastocysts could not be properly cryopreserved. But overall, day 5 is much better to be transferred than day 3 embryos. There were previously some procedures that we used to do before embryo transfer, like mock transfer. Who agrees on mock transfer? Who does mock transfer? Nobody? Nobody does mock transfer. It's a good practice. So it's not red. So some people do it. You can do it before the IVF cycle. You can do it on the day of oocyte retrieval. Some people do it on the day of embryo transfer, but this is not recommended because it might cause more injury. There was an era of an endometrial scratch or injury, and it showed that it's of no importance now. Endometrial receptivity array test, which is an endometrial biopsy done maybe a month before the IVF, and it shows the window, the time of the window of implantation through expression of some genes in the endometrium. Now it's obsolete, it's not done. And progesterone level on the day of transfer. Who does the progesterone level on the day of transfer? Nobody. But is there, a range for the progesterone? For example, if the progesterone is 70, 80, 90 nanogram per milli, is it good? Or if it's 20, 30, 40? Most papers say that it's between 20 and 40 or 20 and 50 is okay. But very low progesterone is bad, very high progesterone is as well bad. As we said, the mock transfer, the timing and the aim. Full bladder, it should be full but not over distended, as we said. Optimum bladder distension, we tell the patient to try to drink 500 mils to a liter 1 hour prior to embryo transfer after she had evacuated her bladder before. So she just feels the urge she wants to urinate and not over distended, and she wants to cry and she wants to go to the loo immediately. Even the over distended bladder in cases of RVF uterus may make the uterocervical angle more pronounced, and this is not good. Definitely the temperature is between 22 and 23. It should be avoid excessive light in the room, and definitely all the instruments like different sized speculums, tenaculums, dilators, everything should be available, and the gynecological couch should be properly in place. The steps. The first step is to gently introduce the speculum. Every step you do aggressively will invite microcontractions to the uterus, and this will allow the failure or will increase the percentage of failure. So first you will introduce the speculum gently to avoid uterine contractions. Try not at all to grasp the anterior lip of the cervix with a tenaculum. No, try not to do that. You will clean the vagina and cervix either with normal saline or with distilled water, sterile water, or with bicarbonated buffered salt solution. Some centers can use as well tissue culture media, but the patient should pay for that. Removing of the cervical mucus with a cotton swab or insulin is very important. Some centers use suction machines. I don't recommend that because it invites microcontractions as well to the uterus. Cervical mucus is very problematic actually. Cervical mucus can block the passage of embryos through the tip of the catheter, can pull the embryo back from the site of expulsion. It can contaminate the intrauterine environment with cervical flora, and this is very important. And this might avoid the implantation of the embryos. It might cause damage to the embryos and improper embryo placement, and so a low pregnancy rate. Definitely do it ultrasound or clinical based, definitely ultrasound guided, definitely. This is the 3D. Is this, what's this? What's this? Is this the embryo? The air. This is the air around the embryo. You don't see the embryo by the naked eye. You see the air around the embryo, which shows the embryo in place. Do we do embryo transfer under ultrasound guidance, transvaginal ultrasound? We usually do it abdominally, but it can be done under transvaginal ultrasound. How come? This is the catheter. So you introduce the outer sheath, and then you remove the speculum. So the outer sheath of the catheter is inside the cervix. And then you place the transvaginal scan, and then the soft or the inner sheath containing the embryos are introduced while the transvaginal scan is in place. As you can see here, the various steps. Catheter here, and then the embryos are placed there. Catheter selection by book, soft catheters are much better than rigid catheters. It might be straight or curved. The length is from 18 to 23 centimeters, and diameter is 0.7 to 1.4 in diameter. You should pass it very smoothly, very smoothly. Tocolytics are not recommended. Insufficient evidence about tocolytics. These are the various types of catheters. The commonest, I mean, in Egypt now, the Wallace is very common. The Labotict or BM catheter is very common. Rigid catheters are not very common in Egypt, like TDT, Friedman, Tomcat, and Rocket. And these are the various shapes of the catheters that we meet. And this is the rigid catheters, various rigid catheters. The loading. Half of the job is on the embryologist, and half of the job is on you, on the gynecologist. So loading, there are three various very common types of loading. Either the embryologist take a bit of air, and then the medium with the embryo, and then the air again. Or medium, air, medium with the embryo, air, medium. But this is the most common type, the first one. Or the medium with the embryo at the tip of the catheter. This is not very common. Why? Because you will not have a good visualization of the embryo while you are injecting it under ultrasound guidance. And as well, the embryo can escape from the tip of the catheter while you are doing the procedure. As I told you, the loading technique, air fluid is the best. It prevents retention in the catheter, protects from the cervical mucus, protects from accidental dislodgement, improves ultrasound visualization, avoid embryo movement to the fundus and downwards. The volume is very important. Some doctors ask the embryologist to put a bit more of tissue culture medium in the catheter so that he feels the yield of the injection under his hand. So he gets a bit satisfied that he injected it. This is not right. So the best volume is from 10 to 30 microliters. More than 60 microliters, it is going to dislodge the embryo, either into the fallopian tube or down into the cervix. There was an era of the embryo glue, which is like a hyaluronic acid enriched embryo transfer medium. It showed that it didn't add much to the success. Catheter insertion, either a single step or a double step. Single step, you introduce both the outer sheath and inner sheath together. Double step, no, you introduce first the outer sheath, and then you are sure that you pass the internal os, and then you introduce the inner sheath. Uterine contractions can happen, as I told you, from the vulsellum or tenaculum, from passage of the internal os vigorously, And from touching the fundus, you should not touch the fundus during the procedure. You should be 1.5 to 2 centimeters below the fundus. As I told you, at the maximum implantation point, which is 1.5 to 2 centimeters from the fundal endometrium. If you are too close to the fundus, don't go back with the catheter. Inject, but you don't do much pressure. Inject slowly without much pressure. There is a rule that from the time of the embryo loaded by the embryologist until finishing the procedure, it should not exceed more than 2 minutes. So there is a rule of 15 seconds. 15 seconds for the embryologist to load, 15 seconds for the embryologist to handle you the catheter, 15 seconds for you to introduce the catheter, 15 seconds for you to inject, and another 15 seconds where you hold the plunger in position. Because sometimes if you injected and then you release the pressure, it might by capillarity move back into the catheter. The embryo can move back into the catheter. And then another 15 seconds that you can remove the catheter out. So the total duration is about 2 minutes. The rule of 15 seconds. Rotating the catheter inside, some papers say that it might help, some papers say that it do not. I think the more you are gentle in the procedure, the more that you will be successful. So rotation 180 degrees, I'm not with that. The duration of embryo transfer, as I told you, it should not exceed 120 seconds. Definitely the embryologist should check if there is any embryo in the catheter after you finish the procedure. Identify women at risk for difficult transfer, and this summarizes the difficult transfer. The tortuosity of the cervix, the swan neck appearance of the cervix. This is the most critical in which you could not proceed with the proper embryo transfer. Definitely, embryo transfer is considered difficult when additional instrumentation is required, when the inner catheter was used, or required a changing of the catheter. Any blood on the catheter, this halvens the success rate of the procedure. Although we have seen many patients with blood on the catheter and they got pregnant, but it halvens the. This is a video on one of the embryo transfers. If you have any comments on that, let's see. This is the catheter is going inside. And it reached the maximum implantation point. And then the inner catheter and the embryos are injected here. And we waited for a bit. And then the catheter is withdrawn. These are the embryos, as you can see. This one and that one. Or the air around the embryos. This is another video showing another embryo transfer. This catheter reached the fundus. Which is better, the first one or the second one? The first one is a bit better than the second one because this catheter reached the fundus and the pressure on the plunger was a bit high. Transmyometrial embryo transfer. Did anybody do transmyometrial embryo transfer? I did it twice and it did not succeed. 2 minutes. definitely it's written down that the Tawoka needle is used, in which the needle passes through the transvaginal approach as if you are doing ovum retrieval, and then the catheter is introduced with the embryos inside or with the embryo. Clinical pregnancy rate is around 22.5%. Could we abandon the embryo transfer on the day of embryo transfer? Yes, if we found these pictures. In cases of severe hyperstimulation, abandon embryo transfer. If you found fluid intrauterine, abandon embryo transfer. If you found undiagnosed hydrosalpinx, abandon embryo transfer. Instructions after embryo transfer, definitely embryos will not fall out. So the patient can enjoy her lifestyle without any problems, eat healthy, no smoking, alcohol, sex, drink plenty of fluids, take all her medications, and de-stress. So this is all the take-home messages. I don't want to go further in it. This might be something about the AI in embryo transfer, in which now they are trying to use a robot to introduce the embryos inside, and they are trying to use a robot instead of the embryologist to inject the sperms into the oocytes. This is a lady who had IVF and was an antiphospholipid antibody syndrome at the same time. So after she delivered her baby, she had all the injections, including the gonadotrophins, including the Clexane, including the GnRH analogs, all together with. And this is, in any presentation, I would like to put this picture. Anybody knows who's that guy? Dr. Amr, do you know that guy? Taranisi. Dr. Taranisi, I was trained with him in the UK for a few years, and I mean, he had the highest standard, highest success in the UK for the IVF cycles for nearly, up till now, I mean, for nearly approaching 20 years now. Thank you.
Thank you, Professor Karim Abba, for highlighting a very pivotal or rate-limiting step, as you mentioned, regarding the timing, skilled execution, and personalization of the cases. Not every case is the same. And now we come to Professor Ala Ismail, who will address us with the great capabilities of AI when combined with minimally invasive infertility surgery.
طبعا
دكتور كريم بيه، هو حضرتك في نقط مهمة قوي أثرتها. واحد، إن الموضوع عاوز اكسبيرينس، مفيش كلام. لابد من توفير عدد كاسكوز ديفرنت سايزز، مش 2 و3. الترا ساوند جايد مانداتوري مهمة جدا، والبلادر فول دي مهمة جدا، تفرد اليوتراين وول، اليوترس تتفرد، ودي مهمة أوي. أنت تعمل سكشن دي ان سي عشان تو افويد أي كومبليكيشنز. محاضرة جميلة براكتيكال. بس شكرا.
طبعا احنا هنقدم استاذنا الاستاذ الدكتور علاء اسماعيل. انا استاذنت دكتور صبحي ان انا بس اشكره. دكتور علاء هو رئيس الجايني انكولوجي في اسيوط يونيفرسيتي and one of the pillars among the world، وعنده حاجات invented by himself ولسه منشور في الجورنال. مبروك حضرتك على اخر انجاز. الدكتور علاء جاي مخصوص من السفر عشان يدينا محاضره عن الروبوتك سيرجري، واهلا وسهلا بحضرتك في عين شمس وموفق.
بسم الله الرحمن الرحيم. طبعا انا اشكر اخويا الغالي دكتور محمد حسين، واشكر تواجدي وسط اهلي وبيتي جامعه عين شمس، وسط اساتذتي العظام اللي انا بتعلم منهم، واولهم استاذي الاستاذ الدكتور صبحي بلوز اللي بتعلم منه كل يوم
يعني ايه استاذ، يعني ايه دكتور، يعني ايه انسان. ربنا يديله الصحه والعافيه ويباركنا فيه، وجميع اساتذتي وزمايلي الاعزاء في جامعه في كليه طب جامعه عين شمس، واخويا الغالي الكبير الاستاذ الدكتور عمرو الحسويني، الدكتور الدكتور محمد سيد، الدكتور صبحي زند، الدكتور يعني كل اساتذتي وحبايبي. انا بعتبر ده بيتي طبعا، وانا شرف ليا ان انا اكون موجود وسطيكم النهارده. انا هتكلم النهارده عن الاي اي assisted minimal invasive surgery for improving the fertility outcome. يعني انا كنت interested في الموضوع الاي اي في استخدامه في الاوبستريك اند جاينيكولوجي جنرال، وكان جزء الاساسي في الاي اي ان diagnosis and management of gynecological oncology، وفي جزء منه مهم قوي المينيمال انفيزيف سيرجري، اللي احنا بنستخدم المينيمال انفيزيف سيرجري not only for assisted production but only for gynecological oncology. بنقول we are in the beginning of the golden age of AI. Recent advancements have already led to invention that previously lived in realm of science fiction. We have only scratched the surface which is possible, which lead us to the importance of artificial intelligence. از دكتور محمد حسين اتكلم عن الارتفيشال انتليجنس. طبعا الكلام عن الارتفيشال انتليجنس والتولز والكلام بتاعه طبعا ده كبير قوي وياخد وقت كبير، لكن هو القصد منه is a simulation of human intelligence processed by machines special computer system. واحنا قلنا زي ما قال الدكتور محمد هم 3 concepts: machine learning, deep learning and neural network. ودي ال 3 components بتاعت الارتفيشال انتليجنس. وبعد كده focusing on enabling the computer to perform the task without explicit programming. وبعد كده بنوصل للديب ليرنينج والنيورال ارتفيشال نيورال نتورك. بنتكلم طبعا زي ما اتكلموا الدكتور كريم، الدكتور محمد حسين والزملاء الاعزاء، ان الانفيرتيليتي تريتمنت facing problem as regarding the success rate for many fertility treatment, not only IVF, patient selection والtreatment program lines of management to how to do which patient is needing for treatment for fertility treatment and which patient is not candidate for it. وطبعا ده بيخلي what is called psychological impact on the success of fertility treatment in general and specifically for IVF cases. Computer vision for AI in obstetric and gynecology has many objectives and many uses، ومنهم حاجتين مهمين جدا انا كنت بتكلم عنهم دايما: الايرلي ديتكشن اوف كانسر and real time surgical assistance، what is called augmented reality to increase the proficiency. ان احنا يبقى عندنا to take your views in real world and integrate it into content that interact with each other. تحس ان العالم بين ايديك، انك انت تاخد الحاجات اللي انت شايفها اللي كنت بتقراها وتحطها بين ايديك وتقدر تحركها في real time. This is called augmented reality to increase proficiency. وطبعا في many tools اللي حضراتكم عارفينهم، الفيجوال رياليتي والجلاسز دي اللي هي متوفره علشان تقدر نستخدمها في الاي اي تايم. الاي اي في السيرجيكال تولز عندنا 3 بيلرز: الاوجمنتد انتليجنس والاسيستد انتليجنس والاوتونوماس. والاوتونوماس is not available in our time till now. لكن احنا one day every day طبعا زي ما حضراتكم عارفين السيرجن في اوضه العمليات using many information to detect how to choose the type of operations before the surgery and the intra-surgery, X-ray, CT scan, MRI, and other patient record to determine the surgical requirement and the procedures. وده طبعا بيبقى noise for the surgeon و take many time and make work overload. Imagine if this records could easily appear in the front of your hand and surgeon eyes without taking their hands and their attention away, and this decreases surgical workload and decrease the time with efficient timing and surgical procedures. AI perspectives, preoperative planning to visualize the structures. AI-assisted virtual reality software generates 3D models based on digital imaging. The virtual reality model can use to perform a virtual surgical exploration, allowing for personalizing the planning and simulation of the treatment. ومن أكثر الحاجات اللي احنا بنواجهها أو بنشوفها في الانفيرتيليتي عموما الاندوميتريوزس. Endometriosis, about 35 to 40% of the female during reproductive age facing or having a degree of endometriosis, and endometriosis taking from 8 to 12 years to be clinically evident. AI دلوقتي ان احنا can predict the risk for development of endometriosis by analyzing different parameters, biometric parameters, DNA and proteins, age of the patient, risk factors by parameters and program. We can use this program to show which patient at risk for developing of endometriosis. The challenge, another challenging problem, and sometimes we see that by clinical picture of this patient may have an endometriosis, and we do a laparoscopy. During the laparoscopy, we found the patient was a frozen pelvis, and sometimes we do, if the surgeon is enthusiastic, we'll do, and he didn't have enough experience, maybe do a surgery was leading to ureteric or GIT, lower GIT injuries, or he ends the problem by withdraw his instruments and go outside. By using AI in endometriosis, feasibility and clinical value of virtual reality to deep infiltrating endometriosis. وده طبعا اتعمل في باريس ان هم عملوا assessing the utility of artificial intelligence in endometriosis, sorry, في لندن, in promising tools for early diagnosis and detection and treatment. وفي استراليا optimizing the detection of obliterated pouch, ان احنا قبل العمليه نقدر to detect البيشنت, to detect deep endometriosis and the degree of adhesions before. So we decide the plan of surgery perfectly, or refer the patient to a center with good expertise in diagnosis and the management of endometriosis. This by integrating different images inside the machine learning, e-learning and deep learning, and using convoluted neural network. This help to surgical technique can be pre-planned, proper instrumentation should be prepared, and potential difficulties is avoided. ومن أشهر الحاجات اللي احنا دايما بتواجهنا في الاندومتريوزس او الجانيكولوجيكال سيرجري والجانيكولوجيكال انكولوجي سيرجري, one of the most important structure which may be altered by the anatomically altered by these diseases is the ureter, with dynamic overlay of preoperative anatomical knowledge atop of the robotic or laparoscopic operative field can outline safe dissection plans, helping the surgeon make critical time intraoperative decision of to avoid the injury of the ureter. وزي ما حضراتكم شايفين هنا ده شكل بالاستخدام الفيرتشوال رياليتي. ده اللي عندنا الام ار اي والاكس رايز اللي اتعملت العيانه, ونقدر بالفيرتشوال رياليتي نقدر نعرف مكان اليوريتر زي ما حضراتكم شايفين. ده شكله هنا فوق بالظبط الستراكشرز او very near to the uterus, and if it should be maybe injured easily, we can do it and integrate it during robotic or laparoscopic surgery to avoid the injury of the ureter. Another disease which is common in infertility is the myomas. واحنا طبعا برضو المشكله برضو في الميوما ان احنا ممكن we can do laparoscopic or robotic surgery for myomectomy and we miss myometrium or myomas or cannot identify actually the site of myomas. احنا بناخد بقى ال MRI finding وبعد كده بنستخدم ال 3D مش موديلز اللي هو بنستخدمه في ال RII والاي اي كان فيجواليز ذا اكزاكت سايت اند نمبر اوف مايوماز. فبالتالي احنا لما بنيجي نشتغل نقدر نعرف المكان بالظبط الاكشوال سايت اند نمبر اند سايز ذا مايوما اند كان وي دو لابارسكوبيك اور روبوتيك مايومكتومي نير بيرفكت. طبعا احنا لما بندخل باللابارسكوب هو احنا ممكن نشوف اليوترس بالشكل اللي هو كبير وبنعتمد ممكن على التكتايل او الشكل ان هنا ممكن يبقى مايوما. استخدام المش augmented AI give us the site and the size where the myomas is found. لكن لو احنا شفنا اليوترس بالشكل ده ممكن نتخيل الميوما هنا او هنا او هنا we do multiple incision لكن the myomas is here and here only and we can do myomectomy easily and safely. من الحاجات المهمة قوي ان احنا وطبعا حضراتكم عارفين ان احنا دلوقتي عشان نعمل حاجه كويسه احنا محتاجين يبقى عندنا well trained surgeon. والwell trained surgeon لازم يبقى trained on human patients on human being يعني. وده ما نقدرش ان احنا نخليه يعمل الحاجه من غير ما يغلط مره واثنين وثلاثه. طبعا ما نقدرش ان احنا ندخله ويعور اليوريتر مره عشان يتعلم مره واثنين وثلاثه. واحنا ممكن نستخدم الاي اي في الفيرتشوال رياليتي علشان يبقى عندنا الباور اوف سيميوليشن ذات از جيفز بيرميشن تو فيل. ان احنا نقدر نغلط مره واثنين وثلاثه من غير ما نعرض من غير to have an harm for the patients. And this environment, laboratory setting, so the student learn from their mistakes. And simulation allow for proper proficiency-based training and objectives. ودي منشورة في الأمريكان كوليج وبتقول إن إحنا لما if we use the virtual reality وال AI simulators ده بيحسن ال surgical expertise from 40 to 70% more than the usual methods of simulator or training. وحضراتكم زي ما انتم عارفين this is AI virtual AI assisted simulator laparoscopic simulator ودي فيها اهم شيء what is called الهابتيك forces feedback. ان انا وانا بشتغل ابقى حاسس يعني هو بيشتغل على السيميوليتور ده يبقى feel that inside the patient not in simulator العادي بحاسس ان this is the uterine tissues, this is the uterus, this is the colon. نفس الريال تايم اللي بيحسه ساعة ما بيشتغل في العيانة العادية وده يديله الجود اكسبيرينس وهو بيشتغل. بعد كده ان هو غير ان دول بيدينا فيدباك على الاكسبيرينس بتاعته مره واثنين وثلاثه. هو نفسه الانسترومنتس دي بتدي فيدباك على الترينرز او التريني ده ان هو يبقى لايسند ويقدر يشتغل بعد كده ولا لا. وده باستخدام ال 2 دي و 3 دي امبريسيف مالتيبل سيرجيكال ونديله مالتيبل سيرجيكال سيناريوز على وان اوبجكتس نقدر نغيره المود بتاعه ان احنا نقول له this is a myoma نغير له بعد كده نقول له this is endometriosis this is cervical fibroid etc this ovarian cyst etc هو يقدر بعد كده يشتغل على نفس الاحساس ده. وطبعا this is model this is most advanced model زي ما حضرتك في simulator. واعتقد ان في جامعه القاهره عند دكتور مناوي عنده السيميوليتور دي اللي هي الارجونومكس ودول تريني وشكلهم في حاجه بيستخدموها كانهم في عيانه موجوده قدامهم. التريني لما يجي يشتغل مثلا احنا علمناه على السيميوليتور ده ان هو ازاي يعمل اوفيريان سيستكتومي مره واثنين لما يجي يشتغل على الريال لايف هيشتغل زي ما كان بيشتغل في الدايم. طبعا استاذنا الاستاذ الدكتور عمرو الحسيني الاخ العزيز الكبير اللي هو ليه البريفليج ان هو كان من اوائل الناس في مصر اللي هو بيشتغلوا في الروبوتك سيرجري، وطبعا ليه ايادي وتعليم لناس كتيره منهم، ناس كتيره جدا في مصر وخارج مصر. طبعا دافنشي 5 واتكلم عنه، دافنشي 1 وهو الهيوج ارمز واستخدامه، وان هو بدانا يعني نبتدي كل شويه يغيروا علشان الارم دي تبقى اقل شويه في السايز، وان يبقى اير او تبقى نوت اير سيلد سيرجون زي ما حضرتك اتكلمت. بعد كده نبتدي نقلل السايز بتاعت الارمز دي، ان احنا نوصل لمايكرو روبوتك ارمز اكشن، وده ديكريزنج التايم ويزود الافشنسي ويبقى روبوتك اندر اي اي اوجمانتد رياليتي. وبعدين ان احنا نستخدم، لان هو العيب الروبوتك سيرجي ان هو ما فيهوش الهابتك فيدباك. ناو with the use of AI ودافينشي 5 في دلوقتي الهابتك فورسز، وان احنا كنا بدل ما كنا كده بدانا نبقى نقلل شويه، ان زي ما قال لنا الدكتور عمرو ان هو يبقى باستخدام المايكرو هاندلنج اند with haptic feedbacks، وان احنا دلوقتي بدل ما كنا بنقعد بالمنظر ده بينا نقعد بالمنظر ده من بعيد والهواء ونقدر نتنفس، ويبقى كمان integrated by AI. Benefits of incorporating AI in surgical robots: data analytic, digitalization of the surgery, surgical workflow analysis, analyzing the surgery, help to avoid the obstacles during surgery and warn of surgery of potential complications, with cognitive with future to have a cognitive robotics analyzing the surgical skills and auxiliary tasks such as control of laparoscopic camera and stretching of the tissues. ده خلاص بقى ما بقيش متعب، فبيقدر نشتغل دلوقتي بأريحية. AI, how AI in enhancing the minimally invasive surgery, advancement in advancing the imaging, data-driven insights and robotic assistance, precision of robotic technique for improving the surgical outcome, robotic arm over enhancing the dexterity and stability, allowing finer movement, microsurgical precision and data-driven insights, personalization of the treatment, predictive analysis and genetic screening, all of these improving the fertility and IVF results with the patient, to increasing the level, the percentage and the prevalence of having a live birth rate, reducing the surgical risks and recovery time. This is the most important task for AI. In conclusion, the future of AI-powered fertility solution, enhancing the precision, as we say again, personalization of the care. Personalization of the care means which patient needs surgery now, which patient needs a treatment, and what's the time, what is the type of treatment for this patient. If we have a patient with endometrioma 5 centimeters, is the patient is need for surgery or IVF or rating of the treatment, AI can personalize the treatment for this patient to have a better outcome and better solution with a greater accessibility for the lines of the treatment. And this is the next step, exploring the potential of AI in different healthcare potentials. And let us discuss the future of fertility care using AI in the next year. We can see many objectives and many machines used to fertility care for patient. Predicting the future is not magic, it is artificial intelligence. And finally, we should say an important statement: artificial intelligence is not a substitute for human intelligence. It is a tool to amplify the human creativity and ingenuity. And finally, thank you for your time.
Thank you very much, Professor Dr. Ala Ismail, for the very informative session. Our next speaker is Professor Zhang Yi, MD, PhD, Assistant Professor and Vice President of Gynecology Department in Nanjing Medical University, China, talking about ovarian cancer PARP inhibitor maintenance therapy. Yes, please.
Thank you very much. Thank you. Thank you all. It's very honored to be here to have the presentation. So it's my first time to travel to the Africa. It's my first time, a long journey, but it's my great honor to have the lecture here. So I'm very shocked about around here. Egypt and China are old countries. We are friends, right? So my topic is PARP advanced reaction management. So I'm a gynecology oncologist. In our department, we focus on the cancer's treatment, like ovary cancer, cervical cancer, and endometrium cancer. So I just heard about the Robert assistant surgeries about Dr. Emerald. So he's very excellent surgeon, I think. But chemo in our department also we use the chemo to prolong the ovary survival of the ovary cancer patient. So drug safety is paramount for sustained disease control by maintenance therapy. Because first, extended disease control resulting in the prolonged PFR and PFS, and acceptable toxicity require the maiden QL. So for ovary cancer, we all know first we should do the primary debulking surgery to reach the residue zero is our goal. And second is chemotherapy. We use the paclitaxel and the carbon. And then we use the step about the maintenance of the maintenance therapy, because it can extend it PFS and platinum-free interval. So due to the optimal efficacy and the safety, chemo is no longer recommended as a maintenance therapy for ovary cancer. Because the GOG 178 study demonstrated the superiority of the 12 cycles over 3 cycles of passing monotherapy has the maintenance therapy in stage 3 and 4 ovary cancer patient follow first line platinum plus paclitaxel chemo. Along the difference in ovary survival was not satisfactorily significant. And the adverse reaction include the rash or shortness of the breast or the chest pain. So in our clinic, we should treat all the adverse reactions. So we hope the drug is very safe, right? PARP inhibitors had good efficiency and safety profile, and now the standards for the maintenance therapy for ovary cancer with extensive application of the PARP inhibitors. New studies cooperate that maintenance therapy with this inhibitor is safe and can prolong the survival of the new diagnosed of the recurrent ovary cancer from the NCCN guideline or in China's guideline. We suggest the ovary cancer patient to take the PARP inhibitor from the first line therapy to the second line recurrent ovary cancer. So the SOLO-1 studies show that the first line olaparib's maintenance treatment significant prolong the median PFS, and the POLAR-1 study showed that compared to other drugs, the olaparib combined with like the BEVA first-line maintenance therapy significant can prolong the PFS. Also, the SOLO-2 study showed the olaparib maintenance treatment significantly prolonged the OS, and especially the BRCA mutation patients. So some guidelines recommended PAPI as maintenance therapy for ovarian cancer, like NCCN and China and ASCO in the USA and CGCS. So we in our country we use the PARP inhibitor from 2018, and most PARP inhibitors belong can in the insurance, you know, the safety data from the PARP inhibitor. So we can see from the table the safety of first-line PARP inhibitor maintenance therapy in ovarian cancer. From we can see the blue one means the dose reduction due to the adverse event. The red table means the treatment interruption from due to the adverse AE, and the green one demonstrate that this discontinuation due to the AE. So we can say the level is not very high here, right? So also we compare the different dose of the olaparib or niraparib. So no matter what's the dosage of the ola or nila, we also can see the rate and the level of the treatment of like discontinuation or the interruption is not very high. Okay, the hematology AE of the first-line maintenance in our country, in our hospital, is not very low. I think it's different from the data here present. In our experiments, like in the first 1 month, the hematology AE is very high, especially the anemia or the neutropenia or the thrombocytopenia. So we suggest patients to take the whole blood test every week. So the price of the whole blood test is not very high, just maybe $1. Yes, $1. Okay. So we also suggest that the ovarian cancer patients like PSR means the current ovarian cancer patient also take the PARP inhibitor. You know, after chemo of like 6 cycles or 8 cycles, the bone of the whole blood is not very strong. Maybe after first month of the take the PARP inhibitor, the whole level of the blood is very low. So here's the AE is more than the first line. Okay, here's the meta-analysis like the olaparib result in a relatively low risk of the AE. Here's the network meta-analysis of the 6 RCT involved 2,000 more ovarian cancer patients, assess the difference in efficacy and safety among 3 market PARP inhibitor like OLA, NILA, and LUCA. And in our country, we have the Chinese brand name like others parade. Yes, we can choose our whole brand. Okay, so you can see the neutropenia, thrombocytopenia, and anemia. Here is the compared to the other 2 PARP inhibitor, NILA induce a high risk of the AE such as thrombocytopenia, constipation, and headache. But in our opinion, the maybe because the weight, and if the weight of the woman is very high, we can choose the Nira, but it's very thin, it's very very thin women, we can choose the Aura. Okay, so in addition, the certain PARP inhibitor have special AE increase cholesterol, and in our experience, if the cholesterol level is very high, it means the ovary survival of the patient is not very good. We now do some basic research about the do the basic research, do the PCR or Western to test the tissue of the patients to hope to get some data and do some research, and increase the calcium and others like rash or cough, but after 3 months of the take the pills, the AE's level decrease very rapid. Okay, so maybe the body can do some very good efforts about the pills. So from the OR has a less off-target effect. It means it can cause very less AEs. Preclinical and head-to-head study compared to the off-target efforts of 5 inhibitors. The PARP inhibitors may inhibit functional protein other than PARP target at low drug concentration level, leading to corresponding AEs. So here is a very famous study of Solo 2 and Nova, and in OR has a favorable safety profile and is suitable for patients on long-term maintenance therapy. And but it's the data in our experiments, two drugs and combine our Chinese brand new PARP inhibitor have the same result, I think. And we also published the relevant paper on 2023 on Medicine Journal. The second part is the management of AE reaction to PARP inhibitor. How we handle the AEs for PARP inhibitor is very important, because people take pills after in outpatient or after home. So if the level of the blood of the whole blood is very very low, may cause very emergent events. So we sometimes get the roundup from the WeChat. Okay, so if the patient have some question, or she can't judge the result of the whole blood, she send the result to me. If I have time, I will respond. Okay, so grading of the severe of the AE. Mild means not very bad, only identified by clinical examination or diagnostic test, no treatment required. 2 level mean that is moderate, require minor or localized or non-invasive treatment. And severe, and the next step is life-threatening and death. But after 5 years of the PARP usage of the PARP inhibitor, no people death or life threatened in our department. Okay, That's a good thing. Okay. The management of the common hematology toxic AE, like ongoing follow-up and dose modification. Here's a hematologic test should be performed monthly with continued follow-up for at least 12 months. Most of the AE can be controlled by dose reduction. Dose reduction is very frequently in our department because most people after chemo they are very weak, right? They cannot take some food or meat or other food, so it can have the bad influence of the AEs. And the bone marrow or blood cytogenic test is recommended if hematological abnormality persists after 4 weeks of PARP inhibitor interruption. So very few women should no longer take the pills because of the AE. Very few. Okay. So the frequency of the blood test of the number of monitor parameters are low the first month of the toxic hematology toxic and the cardiovascular events monitor. So we suggest the first month is important. Patients should go to the hospital to take the whole blood test every week. And if after 3 months, the patient are very familiar with how to handle the AEs, and the AEs rate is dropping greatly. So after 3 months, she may have the whole blood test every 2 weeks, okay, and even more every 2 weeks. And here's a general management process for hematologic AEs. Generally for the thrombocytopenia, like we should first monitor is very important. Like do the whole blood test, and then if the grade increase like grade 4, we should not continue to take the pills. And then if possible, we can take some the infusion like platelet. Yes, if the platelet level is very low and has a risk, has the hemorrhage, and how to manage the anemia. First, also the monitor and continue maybe not take the PARP inhibitor, and if not, if the blood test is very lower, we should discontinue the therapy. And how long can stop the therapy? That is 42 days. And here is the management of the European monitor and also monitor and consider GCSF treatment is very common. Here is the gastrointestinal toxic, like nausea or vomit is very common. And diarrhea is also very common in the treatment of the PARP inhibitor. So we suggest the patient to take some drugs like the anti-emetic therapy to subsequent treatment. Okay. So I will do the summary. The PARP inhibitor are an important maintenance therapy option for long-term disease because some guidelines recommend that. The multiple RCTs have shown that OLR and other PARP inhibitor are favorable safety profile, and it has a few target effects and no specific adverse. And we should follow up the patient about and the management of the AEs. Thank you. So, welcome to China. Welcome to Nigeria.
Thank you very much for your presence in Egypt, your second home, and thank you for the nice presentation and for the innovations you have, and waiting for you tomorrow in the workshop. And it will be very wonderful workshop, and the workshop will be tomorrow in Ain Shams University Specialized Hospital at 9 a.m. Yes, sir, from at 9 a.m. And the professor will guide us through the surgery for lymph node biopsy. Waiting for you. Thank you, sir. بشكر السادة الشير بيرسون، بشكر الاودينس، وبشكر حضراتكم، ونلقاكم ان شاء الله في كل مؤتمر على خير بإذن الله.